we've been sort of skewered on our own successes. So we have a tumor that has an 75-80% response rate up front with a fairly long sort of disease-free interval. But as you know, 75-80% of women with advanced stage ovarian cancer eventually recur, develop drug-resistant disease, and die. In that setting, when pharmaceutical companies come in to test drugs up front, they're looking at multi-million-dollar, tens of millions, if not hundreds of millions of dollars in a clinical trial, phase 3 trial, with probably 6 to 7 years before they get an overall survival outcome, with confounding variables like crossover, other drugs. And so a lot of companies are now beginning to ask if they can't use progression-free survival as an endpoint, is it worth developing their drug for ovarian cancer patients? The poster child for that is bevacizumab. So Bev was conducted probably in probably about 8,000 women throughout the world received it in randomized phase 3 trials. Every trial is positive for the primary endpoint, which is PFS, but overall survival has not yet been shown. And a lot of us think it's because of other anti-angiogenics, maybe the drug wasn't given long enough. There's a lot of different reasons, but I think most people think it's an active drug, and a patient, a woman with advanced stage ovarian cancer, should receive the drug at some point. So when is that? And one of the strongest arguments to give it up front is that we do have a subset of patients who don't do very well. They get sick quickly. They may actually miss the window to get bevacizumab unless we give it early.